guys, it's my first PowerPoint for you guys. I'm going to look at the time. Okay, it's 7:06. I'm going to try to be done with this within 20 minutes because I don't want to overwhelm you guys. This is the most important PowerPoint, though. Hang on to this one. You're going to want to watch this one as you're studying for HESI as well as NCLEX. It's my favorite one because it's about giving birth, which is what I do and what I love. Um, I'm sorry my PowerPoints are getting to you guys a little bit late. Long story short, we ended up with a very short time to pack everything at RMU and get it moved over. So I've spent a good part of the week hauling a lot of crap over to Roosevelt to make sure everything in our lab got to where it needed to be. So, but we're going to get there, and I'm excited for class on Monday, and I'll see you guys all at 9:30, and we'll do some fun things. So, giving birth. Because of birth, we all exist, right? None of us would be here if people didn't give birth. So, sorry, I just made that weird noise. Why did it do that? How do I get to the next slide? Oh, there we go. Okay, so what happens when someone's going into during the birth process? What happens to mom? One of the things that happens is she has huge increased cardiac output during each contraction. During the contractions, actually what happens is all of those spiral arteries get compressed and it just pumps out 400 cc's of blood into the maternal circulation with each contraction. So that's why we worry about stroke sometimes and things like that. But we're going to talk about that when we talk about high risk disorders. Right now, we're just talking about birth. However, we need to always keep in mind when a mom is contracting, we know that those spiral arteries are getting compressed. And what happens in those arteries? Blood and oxygen and waste products are exchanged from mom to baby. So, when a mom contracts, what happens? The baby is essentially holding their breath. Every contraction, a baby has to hold their breath. Now, we know there's lots of reserves of oxygen in the placenta stores, but we need to keep that in mind because if a mom is contracting too much or too hard, what happens? Think about it. If a baby is holding the breath and holding the breath and holding the breath and holding the breath and it's longer, the contractions are too long. Oh my gosh, we start to see the baby's heart rate go boom, 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 and plummet. What's normal heart rate? 110 to 160, 120 to 160, depending what book you look at. I want you to, either one of those numbers are going to be okay. That would never be a wrong answer. It's either 110 or 120 to 160, depending on what book you look at. So think about what happens during a contraction. Why do we contract? We contract because the uterus is contracting to push the baby out, right? So as the uterus contracts, it does two things. It pushes down on the top. Okay, it's thicker on the top and it pushes down to just push the baby down. And then the bottom part of the uterus pulls up at the same time. And it does that to open the cervix. So it pulls and pushes at the same time. That's what a contraction does. It pulls on the cervix as it starts to open it up and pushes on the top to push the baby down. So, what needs to happen to have a baby vaginally? What needs to happen? Three things need to happen. You need to dilate to 10 centimeters. Dilate to 10 centimeters. You need to know this. If I were to give you a 3-number range, the first number is always dilatation, anywhere between 0, no dilatation, and 10, completely dilated. You cannot push a baby out until you are 10 centimeters. Not only do you need to get to 10 centimeters, you need to efface to 100%. That is how the cervix is long and it gets short, 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 and then it opens to 10 centimeters. You need to get to 100% effaced. You go from 0 to 100. Station. What the heck is station? I maintain station is the most important number in this 3-number assessment. Station is where is that baby's head in relation to the maternal pelvis. You could get to 10 centimeters, you can efface to 100%, but if that baby never drops down and doesn't change station, as you know, where you're hanging out, what's your station, where you're hanging, if it never changes, you will not have that baby vaginally. Okay, station, I maintain, is one of the most important numbers that has to. It goes from minus, like, whoa, 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 baby's far away, to 0, where on a vaginal exam, I can feel the head of the baby. You can actually feel the ischial spines on the pelvic bones of the mom through the vaginal walls. When the head is even with those, that's 0. At 0 station, the head is engaged in the pelvis. It's engaged. It's dropped down. At minus station, it's like, whoa, floating up. At plus station, it's about to, it's getting closer, closer, closer. +3, +4, the baby's coming out. So you need to know these 3 numbers. You need to know them: dilatation, effacement, and station. And you need to know what it means. On the next slide, I'm going to show you, this is before someone's in labor. Here's the uterus. I'm hoping this arrow shows up for you guys. This is where the uterus is thick. This is what pushes down on the baby. Prima gravida, remember, someone who's never been pregnant. Multigravida, remember, gravid means pregnant. Multigravida is they've had babies before. Someone who's had previous babies, they're actually going to be a little bit more effaced and often a little bit more dilated, where first-time moms are usually closed, completely closed, no dilatation. Long or thick is what we call. See how this is the cervix here. This is what has to thin, 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 thin. This is 0% effaced. This is 50% effaced. Look at this is 100% effaced. There's like no, maybe 6 centimeters dilated, right? Not quite to 10, but oh no, it says complete. All right, sorry. 10 centimeters dilated. Maybe this is complete effacement thin, but we're only about 3 centimeters, maybe 4 centimeters there. It's hard to tell in a picture like this. Here's complete. This is what I think of complete. Okay. So in a multigravida, complete, that head's really coming down. In a prima gravida, they still got to push that baby down. Okay. So what does that mean? Oops, sorry about that. That means that a multigravidous mom often has a shorter labor because her cervix already knows how to open up and efface, and it just goes faster. But that's not, always true, but that's sort of typical. That is typical what happens. Obviously, you always have those outliers. So this is a great slide because it shows you, here's a cervix. It's closed. Okay, this is where that mucus plug is. That moms sometimes will have some bloody show. That doesn't necessarily mean they're going into labor that night, but it means that as this starts to efface and thin and open a little, you lose that mucus plug, which is bloody show. Okay, so top of the uterus is thick. See how thick it is here? It's pushing the baby down. See how thick it is as they go into labor? That pushes the baby and pulls up. So the uterus pulls and pushes. Okay. So what happens? Well, we know while mom's in labor, she has this increased cardiac output. She often can have a slight increase in white blood cells. Sometimes she can even have a little bit increase in blood pressure. All of that is normal. A little bit of an increase in heart rate. Kind of think anytime you're working hard, right? Doesn't that all make sense? You're working while you're in labor, so it would make sense that your heart rate may go up. Makes sense that your cardiac output goes up. Makes sense that your blood pressure may go up. Remember, though, all of those things can cause maternal complications, and we will talk about that later. I really need you guys, as you're studying at home, to not just memorize, but to start thinking about what it means. So if we learn that a multigravidous mom lives 2 hours away from the hospital, what might you teach her versus a primip, right? That's what you call a primiparous mom or a primigravida mom. From a multiparous mom, you might say, hey, your labor's probably going to be a little bit quicker, so we need to get you here sooner. You need to start putting the pieces together and what it all means. So one of the things that happens when a baby is in labor is they're having this constant, having to hold their breath. Luckily, there's enough circulation of blood that stays in the placenta. We always say babies have about 20 minutes reserves. So if there's a complete cutoff, you have about 20 minutes to get that baby back to a C-section and crash. However, if this baby's been compromised throughout, they may not have the whole 20 minutes of reserves. What happens with the fetal lungs is that the fluid basically starts to absorb into the tissues, and then as a baby is pushed out and comes out the vaginal canal and squeezed, it kind of squeezes more of the fluid out. So let's think about that. If a mom is a C-section baby, that baby didn't get squeezed through the birth canal. Therefore, those babies might be at increased risk for what? Think. Okay, who said respiratory issues? Because you are right if you did. I want you guys to start thinking and putting the pieces together. So, a lot of times when people talk about the birth process, they're going to talk about the 4 P's, the powers. What is the power of birth? It's the contractions and it's maternal pushing. You need both of those powers to have a baby. Can a mom have a baby who's comatose and can't push? No, she would have to have a C section. You have to, she may get to 10 centimeters and contract, but there needs to be a degree of maternal pushing that happens. The passage, oops, I see pelvic shape that's supposed to say. Um, so, what does passage mean? The passage is, can that baby fit through the bones of the pelvic, of the mom's pelvis? Can the baby fit? Some moms have different shaped pelvic bones and they cannot fit through it. More often, though, it's not the shape of the mom's pelvis, it's the passenger. What's the passenger? The passenger is the baby. Just think about this: power, power, contraction, pushing. Passage. Wait, what could passage mean? Where's the baby passing through? Oh, the baby's passing through the pelvic bones. Passenger. Who's the passenger? Oh, that's the baby. What position is a passenger in? And I'm going to show you some pictures of position that will show you why this could matter, how a mom's birth process goes. And psyche. How does a mom feel? All right. A mom needs to have control and feel like she can do it. Anxiety can often stall labors. I don't want you to, memorize this here, but know what happens is because babies have these fontanelles, right? The bony plates are not sutured completely together. The head is able to mold and shape so the baby can come out of the um, vaginal canal, right? So, Mother Nature loves you and is wonderful and makes it so that our heads can move and shape and come out. And so babies can have cone heads for a few weeks after delivery, and that's totally normal. So when I do a vaginal exam on a mom in labor, I can actually feel this fontanelle right here and sometimes tell, or this one, and sometimes tell the position of baby. That is really tricky. I was never as good at that as I would like to be. Um, but I want you to remember the one position that you're going to hear a lot is occipital posterior. Occipitate, that is this backbone of the head. Posterior, and I'm going to show you what that means. A mom who is in an OP position has bad back later because a baby is facing the wrong way. The head, the back of the head is hitting against the maternal tailbone. We call that sunny side up position. So think if the mom is going to push the baby out, the baby would come out literally facing up. That is not how babies should be born. We want them to be facing down. So we don't want them in a occipital posterior position. We want them in a occipital anterior or OA position. Okay, so OP and OA is what I want you to remember. OP, posterior, back labor. OP, just you can remember it that way. Those moms have bad pain in their back. Sometimes we put them on all fours because gravity often will then flip the baby around, or we put ice on their lower back because that sometimes babies can feel that and don't like that and they'll flip. They can have a stalled labor because if the baby is not in a good position, we need the head of the cervix pushing the head of the baby, pushing down on the cervix to help it open. So if a mom stalls out at 6 centimeters, sometimes we think, oh, it's maternal position. This baby is not in a great position in mom. So lie, how the baby is lying in the baby is great, and mom is really great and important. Longitudinal lie, this is what we want, head down. Then we want the baby's going to go through all this process of turning, and will actually, the eyes will actually face the back as the mom comes out. This kind of mom, you could push all you want, but guess what? You are never going to have a vaginal baby this way. Okay, that is a C-section. The baby, this is called an asynclitic position. This kind of mom, you can't see it on ultrasound. This is a great little position here. This kind of mom, but you go to do a vaginal exam and you don't feel this part of the head. You feel nose or eyes and you think, uh-oh. So what we might do, get mom to do squats, get mom to go on all fours, get mom to move side to side to try to get the baby to tuck that chin, because a face presentation can be a very long, hard labor. So different kinds of ways you can see how the baby can be. This is a very difficult type of delivery. It's called a face presentation. Okay, breech. No longer do we do vaginal breeches. If you have a breech baby, you're going to have a C-section. Before any mom comes in for a scheduled C-section, if she's breech, what do you think we do? We put an ultrasound on her because we make sure that baby hasn't flipped. Because if you cut a mom and that baby is not breech and you've given this mom an unnecessary C-section, that is a lawsuit waiting to happen. Okay. So breech, you're having a C-section. This is when you feel, okay, so you go in to do a vaginal exam and you feel for the baby's head. You try to figure out where they are. So posterior, this is the sacrum. Occipital posterior is the back of the head is hitting the sacrum. Occipital anterior, the baby's facing the right way. This takes a lot of practice to learn how to do that. And then you'll say LOA, ROA. That would be here. I'm sorry. LOA, ROA, ROP, LOP. And that's sort of how is the baby tilted. I was never able to do that. That is something that's a really kind of hard skill to be able to do. All different ways babies can be laying in the maternal pelvis. Shoulder, this is another kind of breech. You're not having a shoulder. You're not delivering that. The takeaway from these slides, occipital posterior causes bad back labor. It can cause a longer labor. You put mom in different positions to try to flip that baby. Even if she's had an epidural, you can get her in lots of different positions in bed. We want babies to be in ROA or LOA because that's when it's occipital anterior. And so I want you to think that's the takeaway from those slides. Okay. If any of you can figure out what causes someone to go into labor, you'll be a freaking millionaire because no one can figure it out. We don't know. We don't know what puts a mom into labor. Lots of different theories, and we just don't know. However, what we know happens is there's a change in estrogen. Prostaglandin starts to get secreted. That's what causes the cervix to start to dilate. And so, for whatever reason, someone's labor kicks in, but, we have no idea of knowing. However, what we do know is some things start to happen as a mom gets closer to labor. So remember, term is 37 weeks. After 37 and 0 days, if a mom starts to go into labor and have contractions, go, have at it. Sometimes she'll have what I call false starts, and these are these Braxton Hicks contractions. And maybe mom will contract and contract and contract. We always say drink water and lay down because a dehydrated uterus contracts. And see how you feel. If you fall asleep and wake up the next day, it wasn't labor. It will define itself. Labor will eventually define itself. And after 37 weeks, as long as you're not leaking water, once you break your bag of water, that is your ticket to delivery. We want to see a baby within 18 hours because mom is at increased risk for infection once she's broken her bag of water. Okay? So, you need to know what these terms mean. Braxton Hicks, those are the contractions. Those are those early contractions. They're not, I don't want to say they're not real because they can actually, be painful, but they aren't the kind of true contractions that lead to delivery. Lightning, a lot of moms will say they experience lightning where the baby drops into the fetus or drops into the pelvic bones more deeply. And they'll say they feel lighter all of a sudden. They can take a deep breath because the baby's not pushing up on their lungs. They'll start to have some increase in vaginal secretions. Why? Because remember what I said, you're going to have some spikes in hormones. Spikes in hormones cause vaginal secretions. Bloody show, that's that mucus plug that's going to be a little bit bloody. Or as you start to efface and dilate a little bit, you're going to have some bloody show. That's normal. Bright red bleeding, any sort of pain, soaking a pad, not just a little bit on a wipe, okay? All of those things warrant your ticket to the hospital to be checked out. Decrease in fetal movement, never play around with that. Come to the hospital and get checked out. Some moms will have what's called the nesting instinct, where all of a sudden they have this huge spurt of energy, and you see it all the time. People talk about that all the time, and it's they are washing the baseboards, and they feel this need to get everything organized and ready. And sometimes because you have a fluctuation in fluids, you'll see a little bit of a weight loss right before delivery, and that's totally normal. It's normal for a mom to lose a few pounds before she, those first couple weeks before they go into labor. So all of this is very normal. Many women can have multiple false starts, and maybe it gets them to 1 centimeter or 2 centimeters, and then it stops. And I always tell moms that is 2 less centimeters you have to get through when you're in true labor. So yay, it's working, but it's not true labor. Because what is true labor? I want you guys to lay in bed and say this to yourself 10 times tonight. True labor is caused by cervical dilatation and effacement. True labor causes cervical dilatation and effacement. If you come in and you're 2 centimeters and we send you walking for a couple hours and you come back and you're still 2 centimeters, you are not in labor. You can have little spurts that cause you to open up a little bit, but true labor will cause you to continue to change your cervix. Continue to change your cervix. That is the difference between true and false labor. All right? True labor, your contractions become consistent. They don't go away with walking. They get more increase in pain. They get stronger, longer, and closer together. Stronger, longer, and closer together. And they cause significant change. You may have a little bit of change in your dilatation and effacement, but they cause significant change. So I want you to remember stronger, longer, and closer together. False labor, oh, I have a contraction, I lay down, they go away. Oh, I have about an hour of contractions every 8 minutes, then they go away. True labor, you won't sleep through it, you won't miss it, you won't forget it, you won't be able to watch a movie and concentrate while it's going on. It will get longer, stronger, and closer together. So when do we tell patients to come to the hospital? And we're going to talk about that in a little bit later, but it's called 511. When your contractions are 5 minutes apart, lasting a minute each, and have been going on for an hour. Okay, 511. Or if you break your bag of water at any time, 20% of people, that will be their first sign of labor. If that's their first sign of labor, they need to come into the hospital. Okay, so what are the mechanisms of labor that need to happen? All of these different things need to happen. The baby descends into the pelvic bones. The presenting part, hopefully, is the head. It has to flex and then rotate and then extend and then rotate and come out. So those are all the different sort of positions the head has to go through to get out. And it's actually almost like sideline as a baby comes out. And then they have to, they deliver the head. Is that the hardest part to deliver? No. What do you think the hardest part to deliver is? The shoulder. Because if you have a pubic bone right here and that shoulder can get stuck under the pubic bone, that is a medical emergency. That baby cannot be hanging out with that head out if that shoulder is stuck. When that happens, and we'll talk about that, you put the mom flat. You put her legs all the way up, which is called McRoberts maneuver. And the nurse puts pressure on the pubic bone to try to pop the shoulder out. Worst case scenario, they say what's called Zavanelli, where the doctor pushes the baby back in, but that almost always has very ominous outcomes. And so shoulder dystocia is a very significant complication of delivery, and we anticipate a shoulder dystocia in what kind of babies? What do you think? What kind of baby might get their shoulder stuck under the pelvic bone of a mom? Or pubic bone, pubic bone. That's that bone right there. You can all feel, your men and women, we all have pubic bones down there. That's where the shoulder gets stuck behind. A big baby. What kind of moms have big baby? Diabetic moms have big babies because there's extra circulating sugar. Diabetic moms have big babies. They're at increased risk for shoulder dystocia. What's the biggest issue with shoulder dystocia? There's oxygen deprivation the longer that baby is hanging out. Even though that cord is hooked up, the placenta is still contracting, and there is oxygen deprivation when that head is hanging out because now the baby's trying to breathe at the same time. Shoulder dystocia is a really big deal. Okay, so this shows the station. These are the ischial spines, those spines that are on the inside of the pelvic bones. And I'm going to show you on Monday, we're going to talk about that. That's 0 station, where that arrow is. That means the baby's engaged. +1, +2, +3, you're having a baby. You need to know this slide. You need to know this. This is what we're going to talk about on Monday. You need to know this. How many stages of labor are there? There are 4. What happens? First stage gets you to 10 centimeters and 100% of face. Gets you to 10, gets you to 10. Second stage, push the baby out. Third stage is your placenta. Fourth stage is recovery and postpartum. In that first stage of labor, you have 3 phases: latent, active, and transition. Okay? We're going to talk more about this on Monday in our virtual class. Latent can last up to a couple days. The numbers that we assign to it as far as dilatation have changed, but typically somewhere between 0 and 4, 0 and 6. Your contractions can be kind of irregular, can take a little while to get there. active, you are contracting very regularly. This is when people are coming to the hospital. This is when they're getting their epidurals. This is getting you to 7 centimeters. Transition, the hardest, most intense part of labor. If you are not having an epidural, this is when you are using all your breathing techniques and you are having to pull out all the stops. Moms go through these phases as excited, happy. Oh, I'm going into labor. Oh, I feel contraction. To focused in the active phase. This is getting way more serious. To holy shit, this is the worst thing I've ever fucking felt in my entire life as you get to the transition phase. But Mother Nature loves you, and I owe everybody donuts, but this will help you remember it. I'm being emphatic in my swear words. Mother Nature loves you because she makes the hardest part of labor the shortest. So active, 4 to 6 hours about. It can change for everybody. Transition, short, half hour to 1 hour typically. What may make longer phases? I don't know, a baby in a bad position, right? If that baby is in a bad position, they are not going through the pelvic bones. If they are not going through the pelvic bones, they are not putting pressure on the cervix. If you aren't getting pressure on the cervix, it's not opening up. Maternal position has the biggest and most important effect on how fast labors go. We'll talk about that when we talk about epidurals. Second stage, push, push, push. Second babies, third babies, fourth babies, you may push once. Okay. First time moms typically push between 1 and 3 hours. Third stage is get that placenta out. If we usually see it within a few minutes, if it's more than a half hour, we start to get worried about different disorders of pregnancy, which we'll talk about, like placenta accreta or percreta. Okay, those are words you're going to hear soon. Fourth stage is that sort of recovery phase of the postpartum, those couple days after delivery. Here's a placenta. The dirty side is the side that goes against mom. You can see all the different lobes. This is what sort of is growing on her walls of her uterus, right? And then you have those spiral arteries that dig into mom and come from here and go to the baby. So this whole big area has all those different blood vessels that are all attached to the uterus. This is why one of the biggest complications of labor we worry about is postpartum hemorrhage, because when this placenta peels off, all of the thousands and thousands of blood vessels and capillaries that were attaching it need to clamp off, and that uterus needs to clamp down like a softball. It needs to get hard and round to ligate off all those blood vessels. Here's the shiny side. This is what's next to the baby. Here's a vein, that circle right there, and then 2 arteries. Okay, here's the amniotic sac. So, how long is someone in labor for? Who knows? It's so hard to tell how long someone's in labor. Someone who's never given birth, it's typically going to be a longer labor because your body doesn't know what to do. People who've had more than one baby typically deliver more quickly. However, every labor is different, every woman is different, and every baby is different. First stage can be up to 1 to 20 hours. What's first stage again? How many centimeters? 10. First stage gets you to 10. Second stage is pushing. Third stage is placenta. Keep telling yourself that first stage gets you to 10. Second is pushing. Third is placenta. First stage, you have latent, active, transition. Those are all part of the first stage. People confuse that a lot. Want you to go to the hospital. 511, 5 minutes apart, lasting for a minute for up to an hour. Leaking fluid, bright red bleeding, baby not moving, right? Those are all reasons you should go to the hospital. Why would I put the word taco next to leaking fluid? What the heck am I talking about? If a mom is leaking fluid, we want to know the time when she broke her bag of water, the amount, the color. Is it clear? Is it cloudy? Is it green stain? Could there be that meconium, which is that first stool of the baby? That could be a sign that something's going on. Okay, so time, amount, color, and odor. Taco. That's what we want to know, because once a mom's had a baby, once a mom's broke her bag of water, that is her ticket. We need to see a baby within 18 hours. Some of the things I just want you to really, really, really remember and take away is that the more mom contracts, you have a reduced in placental blood flow. Remember, the baby is holding their breath with every contraction. How do we maximize placental blood flow? We put mom on a left lateral position. Now, we can also do the right lateral, but typically what you're going to see on test questions is left lateral, because supine, what does supine mean when you're laying flat on your back? If you're laying flat on your back, the weight of your gravid uterus, the weight of that pregnant belly, is compressing all those major arteries and blood vessels. Therefore, you need to tilt mom. You've got to get her off those major blood vessels because this baby is already having to hold their breath during labor. They're already having to hold their breath. We need to maximize perfusion, okay? Um, so, what are the things that can cause fetal compromise? You need to know this slide. If you have a fetal heart rate outside of the normal range, that is a sign that something can be wrong, that this baby is compensating. This baby is either heartbeat is beating really fast. We often see that when there's a maternal fever, the baby starts compensating. You will often see a maternal fever in a rapid heart rate in the baby before it even registers in mom, or a low heart rate. Oh my gosh, this baby is, getting less oxygen. Something is going on. It's so important we watch the fetal heart rate. Meconium stained fluid. If you have meconium in the fluid, that baby has passed their first bowel movement in fluid, and they usually do that because they're stressed. They are at risk for aspirating that and when they take their first breath. So we need to take some precautions and watch for respiratory distress. If there's any sort of foul odor in the amniotic fluid, we know that that can be an infection. Okay, that we don't. If mom has a, any kind of, we call it chorio a lot. You'll hear chorioamnitis is when there's an infection in the chorion, in that bag, in that either in the amniotic or the chorion sac. Okay, that's a big deal. That's the layers of the amniotic sac. Those babies need to be followed very carefully postpartum because they can have sepsis and die. So if we notice foul odor, we're going to be taking mom's temperature and we're going to be really watching those babies. What can cause chorio? Maybe the mom had a leak high up in her amniotic sac and she didn't realize it because the baby's head kept sort of blocking off the fluid. Because even if they have their mucus plug in or closed, the fluid can still leak through that. That's not enough to keep fluid in once it were to break. Um, but maybe she just thought it was discharge because it was just a little bit. And so she thinks she's only been ruptured 12 hours, but maybe it's been 3 days. That could be a reason. Maybe the mom has chlamydia. And when she breaks her bag of water, she comes into the hospital and she has chlamydia, and that infection gets up inside there. Those are all things that can cause chorioamnitis. Um, if a mom is what we call hyperstimulated, she is um, contracting, they're longer than they should be, they're happening more often. Why are we concerned about that? Because every time the mom contracts, the baby holds their breath. Okay, if that uterus is not relaxing between contractions, we need it to relax because those muscles ligate off, the muscle fibers ligate off all those blood vessels and keep the baby from getting oxygen. So if for whatever reason we have an irritated uterus that won't relax, that's an emergency. And we're going to talk about that's what happened with me when I was pregnant with Nolan. And we'll talk about that and why that became an emergency. Maternal hypotension. If the mom has low blood pressure, why does it matter? Because the blood's going to go to the mom's vital organs away from the placenta. And then as a result, the placenta is not going to be perfused. And then what happens? The baby isn't perfused. What could cause maternal hypotension? The number one thing that can cause maternal hypotension during labor is an epidural. An epidural can drop a mom's blood pressure. It is the number one complication of epidurals that we watch for. It's why we always give mom a bag of LR, right? Because it's a volume expander before she can get an epidural. It's why we monitor blood pressure so carefully during labor, because if the mom's blood pressure tanks, what's going to tank next? The fetal heart rate. Blood pressure goes down, fetal heart rate goes down. What's the first thing we're going to do? We're going to do our uterine resuscitation, which we'll talk about in another PowerPoint, but we'll start. One of the first things, if you think, would be put mom in a good position, maximize blood flow, left lateral. So then we also have a problem if the mom's too hypertensive, right? Because that can cause vasospasm. So that can also cause problems. So low and high. Know this slide, and don't just know it. Think about, as a nurse, what you would need to do. What do you need to do? Because it's not just enough to recognize that this is going on. You have to know, as a nurse, what is your role to react to these problems. And that's what we're going to talk about on Monday, is how we would react to all of these kinds of things. I love position changes in labor. These are all different kinds of positions. Once a mom has an epidural, all of these things that are in bed right here can be done. I love the peanut ball. I love the birth ball. Um, Tons of different positions. A mom in labor needs to keep moving. You rock the baby through the pelvic bones, you rock them through it. They will get stuck if you don't do that. How do we know a mom's about to give birth? If a mom tells you a baby's coming, let me tell you, I've been burned by that once. That baby is coming. If a mom tells you she has to have a bowel movement, guess what? You better check that perineum and see if that baby's coming. You will deliver a baby once over a toilet and you will not make that mistake again. The same muscles that are stimulated and nerves when you have to have a bowel movement are the same nerves that are stimulated when you have a big ass baby head sitting right there. So, I have to go to the bathroom. I have to go to the bathroom. The first thing you want to do is check, is there a baby getting ready to come out? So, just a quick question. And this is a pregnant woman is at 38 weeks gestation. She wants to know if any signs indicate that labor is coming. Well, what do we know? Weight gain? No, they have a weight loss. Do we have an increase in fundal height? No, that would be concerning. If anything, the baby lightens and drops. Do you have urinary retention? No, these moms are peeing a lot because a baby has dropped and is now putting even more pressure on their bladder. So they can take a deep breath, but there's just more pressure on their bladder. What do they have? They have a surge of energy. They have that nesting syndrome. So that is the birth process. There you go. I took a little bit longer than I said I would, but this is my favorite PowerPoint. We're going to talk in a lot more detail about this on Monday. I hope you guys are all having a good weekend. Goodbye. I'm giving you jazz hands and virtual hugs.